Hello, everybody. Is everyone still awake? I hope. I have the honor, I guess, of being the last presenter on a very long day, so I'll try to be brief. I don't have, as my presenter indicated, I don't have country examples. I'm taking rather a kind of step back to look at, okay, how do we potentially avoid some of these problems with quality? But before I get into that, I'd like to even talk a little bit about what access means, because there's been a lot of talk over the past, well, at the nutrition symposium yesterday as well as today about the availability of medicines, and there's a tendency to use access and availability as interchangeably, and there's a bit more to access, I think. Yeah, and I did it. So this little diagram attempts to kind of describe the 4 dimensions of access. And you'll see that availability is just one of those. There are 3 others. And so one other dimension of access is accessibility. Are the products where the users are? Can users get to those facilities where the medicines are easily? So that's one aspect that we need to take into account. Another dimension of access is acceptability. What are the characteristics of the products? Are these acceptable to the end users? Are they acceptable to the providers themselves? And at a more global level, are they acceptable to policymakers? Obviously, affordability comes into play. Perhaps the products are available, or services, but can the users actually afford to pay for these? And finally, availability. We need to look at if the supplies are there and if there is demand for the supplies. So thinking in those terms for maternal health commodities, this is just an example. In the first column, the percent of births attended by skilled attendants, I pulled these data from the WHO Global Health Observatory, and so they may not be the most recent data, but they're just meant to be illustrative to say that maybe users and, or maybe the products are not as accessible as we think they are, because if these relatively low percentages of women are giving birth where these products may be, we may want to look at those issues. And related to that, when the percentage of women can get to these services where these products may be, are they actually there? And so we see varying degrees. The data in the second column are from the MCHIP PPH and PEE status report from last year, where questionnaires were sent out to ask at the national level if stockouts did happen, and with what frequency. And so we can see that sometimes products are not there, and we've discussed this as well. In terms of affordability, this is an example from a study that was published in 2006 from Bangladesh, from MATLAB. And in the column on the right, we see the total cost of healthcare during pregnancy, delivery, postpartum period as a percentage of average annual income. Now, granted, these total costs reflect much more than the cost of medicine, but in terms of affordability, as you can see, with increasing complexity of care, the prices go up dramatically, right? With an astounding 452%. Of average annual income at comprehensive obstetric facilities. So again, if we look, if I can go back, let's see if I can do it. So if we look at all 4 dimensions of access, this is important to take into account when we talk about improving access to quality medicines and services. And so if we can go on now, another way of looking at it then, oh, sorry, I had one more example. So in terms of acceptability, for example, we've heard this afternoon that perhaps products like misoprostol are not quite yet acceptable to policymakers. In terms of providers, there's examples that where magnesium sulfate is available in facilities, sometimes providers are a bit reticent to use it because of concerns with administration. And then in terms of women, we've seen from the pilots of community distribution of misoprostol that women are okay with taking misoprostol, and there's also evidence that women are also understand the benefits of application of oxytocin. So where we want to be with acceptability is right in the center of that diagram, where the product is acceptable, the medicines are acceptable to all 3 of these groups. So If we want to talk about access then to quality products, and we've heard some of the issues that were found in these varying studies of quality of oxytocin and misoprostol, how do we assure that quality as the medicines flow through the system? So this diagram just represents the different processes during the pharmaceutical management cycle, starting with selection of medicines, flowing through to use, all of this occurring in a policy, law, and regulatory framework with management support systems throughout the process. So let's first talk about selection. In terms of selection, what we like to see is a protocol for case management that's based on a consensus of experts and internationally recognized best practices, right? So if we have that, then our selection process is a little bit easier. We need to take into account the types of health providers at different levels of the system that will be managing these medicines and supplies. Obviously, cost is an important factor. Safety and efficacy, quality and stability as well, what we know about these products, the registration status in the country of these products, their availability for procurement in the country, and then we need to see agreement between the standard treatment guidelines and the essential medicines list. So as the country or the program is deciding what medicines they're going to use for the program, these things need to be taken into consideration. Some specific questions in terms of maternal health commodities, for example, is what about the storage conditions for oxytocin? Are they present? Are they even necessary? We're conducting an assessment in Rwanda, for example, at the moment. And we were looking at cold storage, and then it turns out that the oxytocin that's being used in Rwanda, the manufacturers say it doesn't need cold storage. So those types of issues need to be taken into account. Also, is misoprostol included in the essential medicines list for OBGYN indications? And do we need to consider updating that list? Also, who's allowed to use misoprostol at present? What do the policies say? So these things need to be taken into account as programs are formed, as things move forward in terms of selection. Then if we move on to the next step in the process, which is of course procurement, one of the major issues that gives us a lot of trouble with maternal health commodities is quantification. We need to figure out how much we need. And this is a problem because we're not getting the data that tells us how much we need at present. Obviously, once we have figured out that quantity needed, whatever that may be based on, we need to look into the quality standards, and Peter was talking a little bit about this during his presentation. We need to make sure that our tender documents contain all the information that providers need and that we want to see in our products that describe the quality of the products that we want. And so, for example, we need to look at packaging and what's appropriate packaging for our system. What are the storage conditions within our system? What's the capacity of these storage points along the supply chain to manage the medicines that will be coming through the system? What's the shelf life of products? And I think Victor, in his presentation, emphasized the importance of looking at that. And we also want to look at supplier performance, and there's a lot of talk about pre-qualification, but there's also many, well, no, either misoprostol or oxytocin, and I don't think magnesium sulfate either. None of those products are pre-qualified. So what else can we look at that will help us determine whether the supplier can provide the quality medicines that we're looking for? And another thing to look at is centralized versus decentralized procurement. So how much are we going to procure for the system at the central level? And what's going on at the other lower levels of the system when they're purchasing their own medicines? And we've seen some examples from the private sector. Many times lower level facilities are going to these outlets where there may be potential issues with quality. So here's a lot of questions in terms of maternal health commodities and procurement. Again, do the tender documents provide sufficient specificity on characteristics that affect quality? For example, packaging for misoprostol. Do we need to repackage potentially? In some of the pilots right now, misoprostol is not available in the 3 pill packets, and so repackaging is necessary as we move towards scale up. How's that going to be handled? Again, what data are used for quantification is a major issue. Is data on morbidity available? Most times it's not. Have the needs of the lower levels of the system really be considered? And again, this is another issue that we're really going to need to look at as we move forward with pushing misoprostol down to lower levels of the system. Traditionally, for for example, child health for CCM, this has been an issue, making sure we get the information back from those lower levels of the system so we can actually quantify needs, and we're going to need to think about this. Another thing that comes into play are multiple uses of medicine, of the medicines. For example, oxytocin. How can we nail down that number since oxytocin does have multiple uses? So how much are we really going to need? So all this needs to be taken into account because we don't want to procure too much or too little. Okay. In terms of distribution, again, important part of quality assurance is making sure that as the products or medicines, commodities, whatever, flow through the system, that their quality is taken care of, that the conditions for transportation, distribution are okay, are what they need to be. We also need to look at perhaps quality assessments at distribution points. So visual inspection, are the boxes damaged as they appear in the regional or the lower level medical stores? And so again, with oxytocin, the issues with cold chain, what do we really need to do with that product to ensure that it's okay when it gets to the end user? Again, how are medicines getting distributed to lower levels of the system? How exactly is that going to work? Are we going to wait for the village health volunteers or the community health workers or whatever that lower level is to come to a health facility and pick them up? How often is that going to happen? Is that realistic? Is it really working? What do we need to do to make it work? Yeah, those are the issues for distribution. And then in terms of inventory management, which is also very important, do we have stock cards and registers to show the movement of these medicines? Are these being filled out properly? FIFO is first expired, first out. And so as we saw with Victor, as products age, their quality may deteriorate. So it's important to use the older products first and rearrange the newer products on the shelves. Stock rotation, so that's very important. Reporting is important. Physical inspection, again, are we seeing damaged products on the shelves? We need to get rid of them. We need to dispose of them. Again, disposal of expired products is also important and many times is not addressed properly. And so, again, in terms of inventory management, are we measuring consumption at all levels? Because that's going to feed back into our quantification exercises. So again, thinking about lower levels of the system, how are we going to get that information back up through the system? And are records reconciled? For example, the issue with oxytocin. As medicines are potentially removed in a hospital from the pharmacy to the delivery room, how are we getting information back on what's being used in the delivery room so that, again, we can quantify the needs better and therefore ensure eventually that we're not procuring too little or too much or too little of the product? In terms of storage, we've been talking about this. Victor touched on it in his presentation as well. Is temperature monitoring happening? Does it need to? Is the cold chain being maintained for oxytocin within the facilities? What about humidity and misoprostol? Is there a risk of potentially introducing problems with repackaging and humidity? Again, light, ventilation, and the usual clean environment, absence of insects, rodents, that sort of a thing. And then security issues, because we also want to avoid leakage of supplies, although that has less to do with quality. And then finally, the last step in the process is, of course, use. So again, who's allowed to prescribe these medicines and what implications does that have for quality? What are the indications, dose, contraindications, etc.? How are side effects actually managed? And this gets into counseling. And then are job aids available? And again, is the product available where it needs to be used? Then we have dispensing issues, so labeling, packaging, counseling. I mean, at this point of use, it's really not so much the quality of the product, but how the product is, the medicine or supply is going to be used. And so we need to make sure that we're giving the best instructions that we can. And then in terms of management support, which goes throughout the whole process, we should have standard operating procedures in place that deal with quality assurance, and my time's up, so I'm going to go fast. Our management information system, which of course will help us understand our needs and assist with procurement, human resources issues, financing resource issues, which is enormous, monitoring and supervision. There's been some discussion on indicators. And then finally, all of this happens in a policy and legal framework. And most of my presentation has really been thinking of what goes on in the public sector as medicines flow through a public system. But really, regulation and a strong regulatory authority is really what's going to help assure quality in the private sector. And so thinking about registration processes and what documents are required for registration to assure the quality of products that are entering into the countries, and then also looking at things like post-marketing surveillance. So again, I just wanted to conclude that accessibility, or access rather, is not the same as accessibility. There's much more, or sorry, not the same as availability. There's much more to it, and that assuring quality is not just a one-step process, but rather it needs to occur throughout the whole pharmaceutical management cycle. Thank you.